everyone. Today's topic of discussion is diabetic mellitus. So basically, diabetic mellitus is a metabolic disorder which is characterized by hyperglycemia. Results from defect in either insulin secretion, its action, or both of them. Then, on the basis of cause, it is generally divided into two types: type 1 and type 2. The type 1 is related to autoimmune destruction of beta cell, and type 2 is related to insulin resistance with relative insulin deficiency. So कहने का मतलब है कि पेंक्रियाज में बीटा सेल्स होती हैं जो इंसुलिन बनाती हैं. इन बीटा सेल का हो जा रहा है डिस्ट्रक्शन, जिसके कारण इंसुलिन बन ही नहीं पा रहा है टाइप 1 में. वाइल टाइप 2 में क्या हो रहा है कि मे बी इंसुलिन फॉर्म तो हो रहा है, बट जिस रिसेप्टर पे आकर के इंसुलिन काम करेगा, जिससे सिग्नलिंग होगी आगे ब्लड ग्लूकोज को मैनेज करने के लिए, वो नहीं हो पा रही है. या फिर इन अमीनो एसिड का जो सीक्वेंस है इंसुलिन में, इनमें कोई डिफेक्ट हो जा रहा है जिससे रीडिंग इसकी नहीं हो पा रही है. नाउ लेट्स कंपेयर अबाउट द टाइप 1 एंड टाइप 2 डायबिटीज. As we previously discussed, type 1 is due to insulin deficiency followed by beta cell destruction, and type 2 is due to progressive insulin resistance. So type 1 basically insulin dependent है, and type 2 में insulin resistance आ रहा है. Then what are the common symptoms? These are polyuria, polydipsia, polyphagia, peripheral neuropathy, slow healing wounds, blurring of vision, fatigue, weight loss, and ketoacidosis. The polyuria and polydipsia are the classical symptoms of diabetes, defined by when urine output is greater than 3 liters per day, it is called polyuria, and polydipsia is defined when water intake by the body is greater than 6 liters per day. Let's talk about management. So in management part, we know in type 1 there is a no production of insulin, so we have to give insulin from outside via subcutaneous route. Then second option is dietary modification, in which we will divide the meal in 2 to 3 parts, so there is a slow release of insulin and glucose will be metabolized by it. Third one is exercise, and the fourth one is strict monitoring of blood glucose. In type 2, we have same dietary modification. We have exercise, which increases insulin receptor activity and decreases resistance. We have oral hypoglycemic drugs, acts via various mechanisms, and strict blood glucose monitoring. Previously, it is said that the type 1 is related to younger age group, and type 2 is related to elderly age group and obese. But in few years, it is seen that both type 1 and type 2 can occur in any age group. So classification is age independent, but some books also also mentions that it is age dependent, so we have discussed about that. Now let's talk about the hormonal regulation of blood glucose. So basically, the first regulating hormone is insulin. Insulin is a polypeptide. We can discuss about it later. So it is a primary hypoglycemic hormone. Then how it works? First of all, it increases the glucose uptake by the muscles and adipose tissue via GLUT4. So decreases blood glucose. Second, it promotes glycogenesis and glycolysis. The third one, it inhibits gluconeogenesis, glycogenolysis, lipolysis, and proteolysis. Then, as we have first discussed about insulin, that decreases the blood glucose level. So in body we have also a counter hormone. Let's talk about them. So counter regulatory hormone increases the blood glucose. First of all, glucagon. So glucagon stimulates gluconeogenesis. Gluconeogenesis is a formation of glucose other than from carbohydrate. And glycogenolysis. There is a destruction of glycogen to form glucose. The second one is cortisol, which is also increasing in stress. It also promotes gluconeogenesis and it promotes proteolysis that increases the blood glucose level. Third one is growth hormone. It inhibits the glucose uptake. So as it inhibits the glucose uptake by the muscle and adipose tissue, ultimately it leads increase in the blood glucose level and also promote lipolysis. The fourth one is epinephrine that stimulates glycogenolysis. Glycogen is break to form glucose and other component. Now let's have brief idea about the structure of insulin. So in the figure we can see that insulin has three parts: chain A, chain B and chain C that are linked to each other by disulfide linkage. It is basically a diagram of proinsulin. So when these proinsulin is cut, that is the C chain is removed and we have only A chain and B chain that are linked by disulfide bond. It is called active insulin. The ratio of C peptide and active insulin is 1:1. We have its significant discussion in the later section. So insulin is a peptide hormone containing 51 amino acids secreted by the pancreatic beta cell. We have already told its active form contains only A and B chain that are linked by disulfide bond. So basically it is 51 amino acid in which A chain has 21 amino acid and B chain has 30 amino acid. Now what are the key metabolic actions of insulin? We have previously discussed it increases the glucose uptake by the muscles and adipose tissue via GLUT4. Second, it activates glycogen synthase, which increases the glycogen synthesis. Third, it inhibits the gluconeogenetic enzymes like peptide fructose 1,6-bisphosphatase. Third, it increases the lipogenesis and decreases the lipolysis. The fourth one is increases the protein synthesis and decreases proteolysis. So basically it increases muscle mass. As we have already discussed previously that in diabetes there is a muscle wasting as it causes proteolysis due to insulin deficiency. Let's talk about the metabolic changes in diabetes mellitus. First of all, we talk about the carbohydrate. So in diabetes, due to deficiency of insulin, there is a decreased glucose uptake by the tissue. That may lead to increase in blood glucose level. It also increases the gluconeogenesis and glycogenolysis. That may result in hyperglycemia, glucosuria, that is sugar in urine, polyuria and polydipsia. Second of thing we have to discuss about lipid metabolism. So in diabetes mellitus, there is an increased lipolysis, which may result in free fatty acid formation increment, which may lead to ketone body formation that may lead to ketoacidosis. Basically, ketoacidosis is generally related to type 1 diabetes mellitus, and it is emergency conditions and require immediate attention. Then we discuss about protein metabolism. So in diabetes mellitus, there is a increased proteolysis, which results amino acid used for gluconeogenesis. That is, a gluconeogenesis is a formation of glucose from substrate other than carbohydrate. And we previously discussed, due to proteolysis there is a muscle wasting. So let's summarize it. So we have discussed in diabetes mellitus there will be two things: either there is a decrease in insulin or there is a increase in insulin resistance, which may leads to increase in gluconeogenesis, increase in glycogenolysis, and decrease in the glucose uptake, results in hyperglycemia. Hyperglycemia may further causes glucosuria, polyuria, polydipsia. We are already discussed polyuria and polydipsia are the classical symptoms which further lead lipolysis increment, which results in free fatty acid formation. Free fatty formation may leads to increase in the keto bodies, leads to ketoacidosis, and proteolysis of also occur, which may result in muscle wasting. Now, how can you diagnose it? So, we have 3 to 4 parameters which we will discuss about. First of all, fasting blood glucose. So, fasting blood glucose normally less than or equal to 100 milligram per deciliter. If it is greater than 126 milligram per deciliter, second thing is OGTT, which is greater than 200 milligram per deciliter. Third one is glycosylated hemoglobin, which is greater than 6.5. We have to tell you about this, that it is a retrospective study. It gives average blood glucose of last 3 months. So it's a very good indicator. Third, in urine, glucose at ketone bodies plus 3 plus 4 by urine dipstick test. And we have also told about the C peptide, that we told you that the active insulin and C peptide are present in 1:1 ratio. So in type 1 there is a deficiency of insulin, so C peptide value is low, while it's type 2 maybe there is a normal insulin formation, so it may be normal, or increased, so it may be high, but there is a resistance. Let's talk about how can we make decision for the pathway of diabetes and pre-diabetic. So first of all, we have some tests as we discussed earlier. Now, first one is fasting blood glucose. If it is greater than 126 milligram per deciliter, then it is a confirmed diagnosis of diabetes. But it is in between 100 to 125, then it is a pre-diabetic. Second one is also we discussed HbA1c. If it is greater than 6.5%, it is confirming diabetes. But if it ranges 5.7 to 6.4, then it is a pre-diabetic condition. Now third one is postprandial OGTT 2 hour 75 gram oral glucose test. If it is greater than 200 milligram per deciliter, it confirms diabetes. But if it ranges between 140 to 199, it is pre-diabetic condition. And random blood sugar with symptoms greater than 200 milligram per deciliter is a confirmatory of diabetes. So diabetes is a metabolic disease we have already discussed. Basically, it has complication. that are microvascular and macrovascular. The microvascular is complications is directly proportional to HbA1c value, and macrovascular complication is directly proportional to blood pressure level. Microvascular include some of them like retinopathy, neuropathy, myopathy, while macrovascular include peripheral arterial disease, coronary artery disease, stroke. So, to prevent complication, in case of microvascular, we have strict HbA1c control, and to prevent macrovascular complication, we have to strict BP control. Thank you.